Welcome to the Life Beat podcast, a One Joshua Group production, providing access to information and experts to improve quality of life and health outcomes.
Thank you for joining us. I'm Kermit, Payne, and you've joined Life Beat, the podcast. We're excited to have you join us and share with us a perspective from someone we're honored to have on the program today that will talk more about issues and concerns that pharmacists have looking in our geriatric, our aging population, the importance of health outcomes through medication management. And I believe that once we finish these moments of time, that you would certainly be better informed with a perspective that is honest and giving us through his lived experience how he sees ways that we can better improve our health outcomes. From a perspective of aging, it's important to note that by 2030, 20% of the U.S. population will be over age 65. And by 2050, 23% of the US population will be over age 65. Now, this happens because of the number of citizens within the baby boom population. And as that population ages, the demand for services is going to increase. Probably the cost of services are going to increase just based on economies to scale. But also, there will be a different requirement for social structures related to this demand of service. Joining us today is Dr. Elvin Price, and Dr. Price is the Associate Professor and Director of Geriatric Pharmacotherapy Programs at the Virginia Commonwealth University in the School of Pharmacy, my alma mater, by the way. And Dr. Price studies the impact of genetics on health, aging, and medication safety. He is enthusiastic about fighting chronic diseases, educating the next generation of healthcare practitioners. And Reverend Dr. Price is a pastor of Beulah AME Church in the great, beautiful land of Farmville, Virginia. And he and his wife, Andrea, co-lead the AME Church's Second Episcopal District Health Commission. Dr. Price, thank you for taking time to join us.
Thank you, Mr. Payne, for the invitation. I'm excited about our conversation today, and I look forward to sharing with the listeners and answering questions unfiltered and honestly, and just enjoying this conversation.
We thank you for joining us. We've had discussions before, and in the literature, we talk about who the provider is to the patient, and we'll talk about medication management, but most of all, what health outcomes. And some of the data says that patients have better health outcomes if they have providers who look like them. Now, I know that's a big scenario with a lot of, and is multifactorial, but what is your thought about that? Do you think that the concordance of race does have a significant impact on health outcomes?
Well, I think that it's a very interesting question, and so I've been a pharmacist for 21 years, and I've worked in um, every environment that I can think of as a pharmacist. I've worked inpatient, in hospitals with patients that are acutely ill, those that are severely ill in intensive care units, in ambulatory or outpatient pharmacies, within health systems, within community pharmacies. And one of the things that I've had an opportunity to witness was an underrepresentation of healthcare providers across the board that are from minoritized populations. So it's difficult to say if there were equal numbers of healthcare providers that matched our population. For instance, like in the US, if 13% of physicians were African American, or if 15% were from a Spanish speaking background, or would that improve outcomes? It's very difficult to say, because the experiences that I've had over 20 plus years have been skewed in a sense.
Mhm.
However, I have been able to notice that it seems outcomes seem to be influenced by relationships.
Mhm.
And whatever factors influence healthcare practitioners' abilities to form relationships with
Mhm.
those that they're providing care for, there seems to be a benefit there when relationships allow the practitioner, whether that's the physician, the pharmacist, the nurse, the therapist, the occupational therapist, the
Mhm.
physical therapist, when relationships promote effective communication of
Mhm.
information, of plans, then they're better received. And
Mhm.
that it has been associated with better outcomes.
Mhm.
And how do we um, investigate the relationship forming between healthcare practitioners and those that are being cared for? I think that might be a good question and it give us some answers. And
Mhm.
maybe that work has been done and I've been too busy reading literature on other topics and I've missed it.
Mhm.
But I think that relationships are central to
Mhm.
having great communication and great outcomes.
Mhm. So I think that you spoke to the real issues: communication,
Yes, sir.
that personal relationship, and these look actually into race concordance, deal with trust. So
Mm,
I think those two components of race concordance really are what would impact health outcomes, other than people taking their medication as it has been prescribed. Um, so medication management, adherence, compliance to medication. Do you see that as being a challenge in impacting health outcomes?
absolutely. Um, medication, medication adherence, or as in some circles, you see the term medication self-management or
Mm,
medication, the capacity of an individual to manage their medications influences outcomes. And so the classic approach to adherence of just follow directions is maybe falling out of favor for more nuanced evaluations of medication self-management and
mm,
capacity. So for instance, we can give someone we can give someone instructions to follow that they physically cannot follow. They may not have the dexterity in their hands to perform an injection, or the
mm,
dexterity in their hands to, or have the vision to draw up certain um, amounts of injectables.
mhm,
And that's limited by capacity. But
mhm,
relationship and communication, if we have relationships in place and communication, we can understand someone's capacity to follow instructions or to understand what they are doing, in terms of a prescription. There's a model that we are implementing in some of our geriatric clinical services here, where we're borrowing from the Minnesota medication self-management model.
mhm,
That is a simplified approach of understanding key things about medications and simplifying this, and using that as a way of helping the patient understand what the goals of treatment are, what their
mhm,
medication is supposed to do.
mhm,
What does it look like if the medication is working well? What does it look like if something is wrong? Like, what is a troubling side effect? And can you complete the task? This simplified approach,
mhm,
we believe, is going to help us with our adherence rates for our particular patients that we are providing care for.
mhm,
So, do you understand what the medication is for? I
mhm,
need to be able to explain this in your language that you can process and that you can teach it back to me. And what are the goals? What are the outcomes that we expect? What would be a bad outcome? And do you have the capacity
Mhm.
to take it as it's being
Mhm.
prescribed? When the answer is yes to all of those things, we have better
Mhm.
outcomes um, for patients we're providing care for.
Mhm. So you've used, I was just thinking, I don't recall getting medication or my healthcare practitioner, be it dentist, be it physician, mentioning self medication, self management to me. And I think many patients still believe that even though I am the one taking the medication, it's still the provider's responsibility. But the provider wrote the script, made sure you could get it. It's up to you to manage your medication. I don't know that patients walk away believing that. You have thoughts about that?
That might be a great observation. And then there's some difficulties that come along during the process that add some complexity.
Mhm.
One of the as we were investigating this approach of medication self-management and
Mhm.
determining how capable people are of managing the medications that they're receiving,
Mhm.
one of the things that we discovered from the participants that adds complexity is the fact that generic medications, their appearance may change every 3 months. And just the appearance throws someone off that has been in a routine for 3, 6, 9, months. And then all of a sudden it's not a small round pill. It's now long and yellow. And
Mhm.
and and these changes that are of no fault of the patient
Of the
sometimes
patient.
throws them
Mhm.
off on based on how they were in the mindset of training themselves to follow the instructions.
Mhm.
I take the white one in the morning, the pink one at lunch, and when the white one turns to blue or into yellow, sometimes it confuses them and
Mhm.
adds complexity that is, if it was avoidable, it could give us a chance to have better outcomes.
Well, I'm gonna tell you that, I've experienced what you just said, so I know what the pill looks like. Nobody told me that it was not gonna be yellow anymore, that it was gonna be white. And then when I look at my medications, there are 2 pills who look exactly the same, same size. One has a different scoring on it.
Yes.
So you just don't take either one. So I think that because you're concerned about that. So maybe that's something, we can kind of be sure that there's a regimen by which you can change the way the pills look. But you also mentioned the difference in a generic medication versus
Yes.
a branded medication and the relationship of self-management. Should we be concerned that something is generic versus branded? And what is the value of one over the other?
Well, the generic the generic and brand argument is, it should be a moot point. Um, but there have been occurrences that contribute to the public's lack of trust with some generics. So there have been some incidences where um, generic manufacturers had bad inspections when the FDA visited, or data that were missing from equivalency examinations and testing. And so there's some general skepticism in the public, and there's some reports from some individuals who swear by brand only. But there are there are reputable generic manufacturers where patients never complain about
Mhm.
certain generic manufacturers, and that should be the case for all of them. You have the formulations public when the patents
Mhm.
are gone, and the there should be equivalency there.
Mhm.
Theoretically, there should be equivalency, but it's like our favorite brands of food and beverage. Sometimes there's some that we just prefer over others,
Mhm.
um, and that seems to be the case with
Mhm.
brand versus generic. Personally, I whenever I could have an opportunity for a generic, I would go with that choice. But I have witnessed patients that swear by certain manufacturers,
Mhm.
and it was and I can't say that their experience was not
Mhm.
accurate in the way that they described it. So
Mhm.
technically, they should be equivalent.
Mhm. So you mentioned you're practicing in the various environments, hospital based, um, and which is a different clinical base, and also community pharmacist. So
Mhm.
the community pharmacists are very different than the community pharmacists that I remember them to be. But community pharmacists are the first line of access, and I'll step out on experience here for healthcare. I didn't say just for medication, but for healthcare, because I think uh, many people get the prescriptions that they get and they want to know what the pharmacist thinks about this. So that's where the medication management takes place at the pharmacy. Even though I think it should be a partnership, what kind of questions would you suggest a patient ask of their community pharmacists? Well, community pharmacists are branded now. We don't have a whole bunch of those real true community pharmacists, but you get a new medication from your provider, a medication for which you're not familiar.
Yes.
And you go to the pharmacist, and the pharmacist says that you read this, and the pharmacist says, "Oh, so you have peripheral arterial disease." And the patient says, "No, I don't have that. I have something else." So, what should be the question when it looks like you've got a new medication and you go to the pharmacist? What should you ask the pharmacist?
It's a great question. And I'll go back to those major things that I covered in the Minnesota model of
Hmm.
medication self-management. And the first thing is, when asked, do you have any questions for the pharmacist? I would start with answering yes, and I would request a consultation. And the first question would be, um, you know, what is this medication commonly used for?
Hmm.
Or what is it indicated for?
Hmm.
And are there any other uses for this particular medication? And that question should cover why you are getting it,
Hmm.
and why you're getting it should be included. So there's sometimes the primary or secondary reason that a medication is approved may not be the reason that you're getting it. It may
Hmm.
be something further down in the list. And so understanding why you're receiving this and communicating to the pharmacist, well, this is what's going on with me, and this is what I was told. After hearing that, it gives you a chance to ask, so how would I know if this medication is working well for me? And the pharmacist can say, your blood pressure that you're checking at home on every morning, or however many times you're checking it, should start to trend down after
Hmm.
however many days. So understanding what good results should look like for this particular medication,
Hmm.
that's always helpful to know. And then I would ask also, well, what are the common side effects that happen with this particular medication? And then in the printout, there should be, a list of some of those things, but that printout might be 10 pages and the words may be small. So I would ask about those major
Mhm.
uh, concerning side effects, and then um, take a look at the bottle or the package to make sure that you have the ability to read it,
Mhm.
to
Open
remove
it.
the cap, to
Yeah.
yes, to open it or to
Mhm.
administer it. Make sure all of those things with the pharmacist there to help before you're
Mhm.
gone. Um, I've seen some I've seen some cases where the patient with some of our newer injectables that may
Mhm.
have a taper, meaning you start at
Mhm.
one dose and
Mhm.
then you increase it over time.
Mhm.
I've seen mix-ups where the patient either did not understand or they did not receive full counseling maybe
Mhm.
on dosing, and then there are errors with dialing the dose or with administering, and that could have been caught in the counseling.
Mhm.
And I would also ask how many refills, like, do I have any refills, and
Mhm.
how often should I, expect to feel this? Those are some basic
Mhm.
questions that you should know before leaving.
Yeah. So, Dr. Price, that side effect profile, I'm not taking that. I'm not having no seizures. I'm dry mouth, dry eyes. I'm okay with that, but I'm not going to be falling out in the street. I'm going to have a heart attack. And so, tell me, how do we get through? Because we read the side effects. You probably don't want to take the medication. Should we be overly concerned about the side effect profile?
Um, I I not say overly concerned, but for me, it has helped to be honest with patients. So the if there are side effects listed that happen in 2% of people taking a particular drug,
It's
I can
listed.
honestly tell them
Mhm.
and say two out of one every 100 people who were taking this medication in the studies and in the post market
Mhm.
monitoring experience dizziness. But being able to communicate that risk in terms of number of people per 100 or
Mhm.
1,000 or whatever sort of helps that person to have all of the information necessary to
Mhm.
make the choice if it's something that they want to
Mhm.
to try. And that has been helpful for me in this modern day of social media side effect groups where
Mhm.
people are counseling each other on social media groups, and it makes people
Mhm.
concerned about safety
Mhm.
profiles of
Mhm.
medications. And when the people arrive with their Facebook groups, I pull out the numbers from
Mhm.
the labeling materials from drugs or from wherever resources I can find, and we do the math. And so I can show
Mhm.
you this is what your
Mhm.
risk profile looks like, and you can make a choice from there. And
Mhm.
usually people choose to stay on their meds or
Mhm.
they make the best choice for themselves.
So again, all this is personal. That's speak from that. But I do know that when you read the side effect profile, that you really should pay attention to that because it may happen to you once every 3 months.
Mm.
But then to know that that's the case, and the dizziness that happens with so many medications, I think, from talking to people that I speak to. So the risk, the side effect profile is there for information, and people who are taking the medication should certainly read and be aware of it and report that to their pharmacist and to their provider. There's nothing like taking notes and writing that down. Your providers don't really get freaked out when you go with your phone and you pull up your whole page of everything that happened to you, and you keep your blood pressure every day at 10:05 every morning for a month, and what you read on social media and in the broader spectrum of things. You mentioned social media.
Yes.
Tell us about the relationship of information on social media and or misinformation, and what the value of that is, the source of credibility.
So one of the one of the things that emerged from the COVID
Mhm.
pandemic was everyone became their own researcher. You know,
Mhm.
there's an overabundance of people now who I do my own research. That's
Mhm.
like one of the quotes that you hear now. I do my own research, and um, I never immediately reject the things that patients bring forward from their own research, right? I
Mhm.
never reject it straight away. I always
Mhm.
listen to people, hear them out, and then I we can compare the information that you have, we can compare it to the labeling materials
Mhm.
for drugs. So for drugs, you have the labeling material that are free and publicly available. And the data from the studies that help to get a drug approved,
Mhm.
and then all of the wealth of information in reputable peer-reviewed journals that are industry standards for certain things.
Mhm.
So even if I have a patient that only has a sixth grade education, and that person brings their own research from home,
Mhm.
I I I read it, filter it with them, and then we pull up the labeling materials for the particular drug that they're concerned about, and then we work through the numbers, and we go through publicly
Mhm.
available literature so that they can understand that I didn't just dismiss what you were concerned about, but here are some alternative data, and you can decide what the facts are, and usually they go along with the more supported
Mhm.
um, materials.
So, Dr. Elvin Price is the Associate Professor and Director of Geriatric Pharmacotherapy at Virginia Commonwealth University in the School of Pharmacy. And he's been very kind to join us today. And Dr. Price, we've talked about aging and we've talked about medication safety, but we've not talked about this impact of studies on genetics. Tell
Mm.
us about that.
Yes. So um, there's genetics influences um, the efficacy of medications and safety of medications. There's this growing understanding that the ways that our bodies eliminates medications. So
Mhm.
after we take them, or we apply them, or however we are um, interacting with the drug, our body has these natural defenses to eliminate compounds that come into our body,
Mhm.
and those routes, if we they are influenced by genes, like our blueprint for making our bodies.
Mhm.
It can vary based on our ancestry, and it can vary based on these variants that showed up over time, the history of people living,
Mhm.
and experiencing different things all around the world, and it's influenced our ability to survive certain
Mhm.
things we've influenced. But our major routes of getting drugs out of the body, depend on our liver, they depend on our gut, and genetic variants that influences how those processes work in our liver, in our gut, can influence how efficiently we kick drugs out of the body.
Mhm.
And those are some of the lower hanging fruit, but super impactful fruit, in reference to medication safety and efficacy.
Mhm.
So there are um, lots of drugs that are FDA approved, where we now have markers
Mhm.
that are in the prescribing materials that tell
Mhm.
us if you have loss of function of your liver being able to do this certain thing, this particular drug will be bad for you, and it can cause most likely that you'll be more likely to have a side effect, or the drug may not work at all
Mm-hmm.
because you are missing this particular protein. So it is something now that over these about last 20 years or so, the science has grown in a way that has produced reliable results that are now now they're ready to be implemented into care and
Mm-hmm.
covered by insurances. And so is just like another tool in the toolbox of your healthcare team
Mm-hmm.
that they can use to um, optimize your outcomes. You know,
Mm-hmm.
it's sort of just like having a blood pressure
Yeah.
number or a cholesterol exam or having your blood glucose levels. Knowing if you can effectively process a large
Mm-hmm.
percentage of prescription drugs is another tool
Mm-hmm.
that saves us um, saves us time and money and heartache and helps to try to have better outcomes.
So you talked about outcomes and these toolkits. So that brings us to another discussion of technology. What's
Mm,
on the horizon in the world of pharmacy for technology that's going to help us maintain? We always looking at improving. Sometimes we just need to maintain where we are.
mm,
What is on the horizon for technology, or what needs to be explored? Another
mm,
perspective in technology around
mm.
pharmacy care.
Uh, there, there's lots of digital health related
Mhm.
innovations that are happening um, in um, in pharmacy. There are new tools to help with remembering medications or simplifying the routes that the
Mhm.
scheduling of medications that are being developed. There are studies evaluating combination pills that have
Mhm.
in instead of having just two medications maybe in a combination pill, there have been studies going for a while evaluating maybe five essential pills to get like combined in one tablet or three in one types of approaches to simplify the regimen
Mm,
and with hopes of optimizing your
mhm,
your effects on common disease states. And
mhm,
then there are lots of targeted therapies that are being developed um, in the cancer space.
mhm,
There have been a boom of new targeted drugs that specifically target proteins that are
proteins,
over
mhm,
or under expressed on a
mhm,
particular tumor. So there's
yeah,
lots of innovation happening in the pharmacy space or in
mhm,
drug development that are being more effective year after year, just getting more effective at it because we have more tools in our toolkit.
mhm.
We can try to do a better job of developing therapies.
So, Dr. Price, patient A is overwhelmed
Mhm.
by their medication regimen. What do you tell them?
Someone that is overwhelmed. I, I first try to establish a relationship
Mhm,
with that particular person. Is step one might be relationship building. It might be
mhm,
finding common ground and understanding why they are overwhelmed. I have some like a few cases that popped into mind
mhm,
um, with different individuals that were overwhelmed for external reason. Give an
mhm,
example, two examples. One was a case where a patient quit all of their diabetes medications, quit everything. and came into clinic, and the physician sent me to talk to him first. Like, so you go in and meet with him first. He's checked in. And the reason that he quit all of his medications, his mother had just passed away. You know, she had a stroke in her 90s and she didn't survive. So he was overwhelmed with grief. And we started to have a conversation around, you know, things that he enjoyed, and we built a bond around the thing that he enjoyed. And at the end of the conversation, I was able to get him to start one medication back. So he started one step at a time to as the grief became more manageable, we could be a little bit more purposeful around his therapy. It may not have been ideal, but it was one step at a time. Another case, we had this new patient that was starting services in our particular clinic after surviving a heart attack. So he had an MI, he survived it, he came back home and did not want to do any of the medications. And it was a complex case, and we got him to start one afternoon tablet as the start something. Well, I understand you had a heart attack, and this particular pill right here, it's shown to prevent a second heart attack.
Second heart attack.
And that was the starting point. Just starting that afternoon beta blocker to, you know, and after that, later on, we were able to approach his diabetes, which was completely out of control, right? And then after that, some time later, we were able to approach his dental needs and helping him to make it through, like to navigate to the like different issues that he was having over time. So I start with building a relationship to understand where the overwhelming, like where this sense of being overwhelmed comes from. And then a little bit by little bit, we can get things under control, and I can help you understand what the medications are for, what the good results should look like, what would be some concerning things, and then we make sure that you can manage what you are doing. This one particular, that one example that I gave, after the heart attack, this person would then start to bring their medications in their box, like a organizer. And then we started to double check to make sure that the patient was able to put the medications in the organizer correct. And it gave him something to do, to organize his medications. And he felt that he was getting something accomplished every time we double checked, and they were, hey, you did it all right. And so that's sort of my approach. And then there's also sometimes in transitions of care, some medications get left going that should have been stopped. So sometimes the pharmacist can help to see if something needs to be stopped. So we call it deprescribing. And that means to remove something that sometimes things get doubled up, or they were only intended to stay for 6 months or a year. We try to help with contacting those providers to say, do you want them to stay on it? And so that's another way of simplifying when we can. And yeah.
So in the days in another life, in my high blood pressure days, we did multiple screenings every week at somebody's church, and somebody's parking lot, and somebody's grocery store. We do them in your house, and barbershops, beauty shops. It was so interesting because they were more interested in bringing their bags of medication to see the pharmacist than they were getting the other screening. So we don't see as many screenings, at least I'm not aware of them. We're screening for other things. But having that general kind of informal settings, I believe was very, very helpful for many people. Now, the last two things, Dr. Price, is what message would you like to leave with our viewing and listening audience today? And again, thank you so very much for taking the time out to tell everybody. We just had the last few minutes when a pharmacist don't think you're going to get that amount of time when you go to your local pharmacy. But at least we have some armamentarium of questions that we can ask a pharmacist. What is this for? Number one, why did my doctor, my provider prescribe this for me? That's the first question, so that you understand the need for that medication. And then others would come from that. And I believe, Dr. Price, we always see that the pharmacist is so busy. And personally, I've been reluctant to ask for a consultation. And I think we have to give up something to get something. If you have to wait 40 minutes, 30 minutes, then it will be well worth the wait to do that. I just wanted to add that. So what do you think? What message would you like to leave with our audience today about being a pharmacist, about medication management, about medication safety, and about getting old and taking medications, aging? I'm sorry, I should have said that properly, about aging and about genetics. So what say ye about that?
Sure. If whenever possible, develop a relationship with your pharmacist. If you have prescriptions that are being filled in a community pharmacy, take advantage of the opportunity to build a relationship with the pharmacist. If there are two pharmacists that work in a community pharmacy that you are using, get to know both of them. And so
Mhm.
that means arriving early or arriving just after lunch, whatever way you can try to build in time for a relationship with the pharmacist is worth it. Is really worth it. And if you can use that pharmacy for everything, for all of your prescriptions, then you have an extra layer of safety built in. So
Mhm.
sometimes our primary care providers or specialists don't all their electronic systems don't always communicate. And so they may not know everything that's going on in your situation. But the pharmacist, if you are filling all of them in the same place, you have a safety warrior on your side
Mhm.
there that can evaluate things for you and build rapport.
Mhm.
And you can share information with them. You can, like, if your blood pressure is running high, then you have someone there that is a uh, um, first level of communication that you can
Mhm.
share data with, that they're an advocate on your side and they can help get
Mhm.
that information over to your healthcare provider. So
Mhm.
I would say try to develop a relationship with your community pharmacist if you're one that is filling prescriptions. Um, ask them questions about everything
Good.
and put them to work. They have lots of skills, um, and there are lots of wonderful community pharmacists out.
Mm. So, Dr. Elvin Price at Virginia Commonwealth University School of Pharmacy, it is always our pleasure, my brother, to get to um, enjoy the information that you provide. We thank you. We didn't talk about this part, but we thank you for the work that you do in your communities. That's plural. So thank you and your family for the work that you do in the communities. I'm Kermit Payne. I'm your host for Life Beat, the podcast. I think Dr. Price and I have resolved the problems of life today: trust and communication. So
Yeah,
we improve our trust and improve our communication so it is not transactional. I think we'll be okay, Dr. Price. We can get
yes,
through a
sir.
lot of other things. So, again, thank you for joining us, and thank each of you for joining us. And we'll see you soon. Remember to be kind to yourself and be kind to others.
We would love to hear from you. Send your listener letters, questions, and topic requests to media@the1jg.com. LifeBeat, the podcast, is sponsored by One Joshua Group, your strategic source for engagement to improve life through better health, education, and information. To learn more, visit us at the1jg.com or follow our work on social media using hashtag #OneJGCollabs. One Joshua Group, advancing access to healthcare and education by joining what you know with what we've learned.